Imagine walking into a pharmacy, picking up like an everyday over-the-counter headache pill, and knowing that taking just a few extra could trigger acute organ failure.
Yeah, it's a terrifying thought, honestly.
Right. Because, usually when we talk about medicine, there's this expectation of total precision. It feels almost like engineering.
Exactly.
You have a headache, you take a pill, the headache goes away. It feels very binary, very safe.
It is deeply comforting to think of it that way. I mean, we naturally want to imagine that a drug simply goes into the body, performs its one designated job, and quietly leaves without touching anything else.
But then you look a little closer at pharmacology. For today's deep dive, we're pulling from a massive stack of sources. We've got pharmacology textbooks, historical medical journals, and some pretty dense FDA regulatory guidelines.
Very dense.
Yeah. And looking through all of this, that illusion of perfect safety completely vanishes. We're looking at a landscape defined by a terrifyingly razor-thin margin between healing you and harming you.
Absolutely.
So today, we are exploring the therapeutic index. Specifically, we're focusing on narrow-therapeutic-index drugs, or NTI drugs. Yeah. And our mission for you today isn't just to memorize some medical concept. It's to understand how medical professionals navigate this treacherous gap and why understanding this margin changes everything about how you, the patient, should view your medicine cabinet.
When you grasp the mechanics of this, you stop looking at medications as, simple on and off switches. You start seeing them as powerful chemical interventions that demand profound respect.
Okay, so let's unpack this. I was thinking about how to visualize this concept from the textbooks, and here's what came to mind. Imagine parking a car.
Okay, I'm with you.
A drug with a wide therapeutic index is like parking a tiny compact car in an empty, massive stadium parking lot. You could be a little sloppy.
Right, you can park diagonally, whatever.
Yeah, you're generally safe. But a narrow therapeutic index drug, that is like parallel parking a wide, heavy truck on the absolute edge of a cliff. A tiny miscalculation, a slight slip of the foot on the pedal, means absolute disaster.
That framing captures the stakes perfectly. At its heart, the therapeutic index formalizes a question that every single prescriber and nurse intuitively asks every time they hand a patient a pill.
Which is what?
Well, it's basically, how much error does this drug forgive? A wide margin forgives a lot of biological noise. A narrow margin forgives absolutely nothing.
Wow. Okay, to really get how we measure this forgiveness, we have to look at what the textbooks say versus how it actually works in human bodies. The classic textbook definition is this strict formula. It says the therapeutic index equals LD50 divided by ED50.
Right. And breaking that down mechanically, LD50 stands for the median lethal dose.
Yeah.
That's the exact dosage that kills 50% of a test population. And the ED50 is the median effective dose, meaning the dosage that produces the desired healing effect in 50% of that same population.
Got it.
So mathematically, if your TI is 100, you have a huge comfortable gap between the dose that helps you and the dose that kills you. But if your TI is 2, the dose that heals sits dangerously right next to the dose that harms.
Wait, hold on. Finding an LD50 implies that scientists are actively dosing subjects until half of them die. Obviously, we do not do that to living human patients in a hospital.
No, absolutely not.
So how is this formula actually useful outside of a textbook?
Well, that formula is strictly confined to animal toxicology during the preclinical trials of a new drug.
Oh, okay.
Yeah, we use mice or rats to establish the baseline chemical toxicity. Once a drug actually reaches human trials in clinical practice, that textbook index is translated into a much more practical concept. We call it the therapeutic range or the therapeutic window.
So the window is the real-world human version of the index.
Exactly.
Looking at the clinical guidelines in our sources, this window is defined as a specific band of drug concentration in the blood. It's bounded on the bottom by the minimum effective concentration, the MEC.
Right. If you are below that, the drug basically does nothing.
And it's bounded on the top by the minimum toxic concentration, the MTC. So when you hear nurses and doctors talking about checking a patient's levels, they're talking about staying inside this specific blood concentration window.
What's fascinating here, though, is that even with this defined window, relying on medians, like that 50% mark, is currently a subject of intense live debate in pharmacology.
Really? Why is that?
Because a median-to-median comparison only tells you about the typical, mathematically average patient. It completely obscures the vulnerable outliers sitting at the edges of the bell curve.
Oh, I see. The people who don't fit the average, like the elderly or someone with impaired kidneys or maybe
Mhm.
someone who is genetically just a slow metabolizer.
Exactly. A drug might have a perfectly comfortable median therapeutic index for the general population, but still build up to incredibly toxic levels in a patient whose liver doesn't process chemicals at an average speed.
That makes total sense.
That's why many pharmacologists push for an alternative metric called the certain safety factor, or CSF.
Yeah, I was reading up on the CSF, and it changes the math entirely.
Mhm.
Instead of looking at the 50% mark, it calculates LD1 divided by ED99.
Right.
So it takes the dose that is lethal to just 1% of subjects and divides it by the dose that is effective in 99%. It explicitly forces regulators to look at the dangerous overlaps at the extreme edges of human biology.
Yeah, rather than hiding those risks inside a comfortable average, it is a much more rigorous standard for safety because it acknowledges biological diversity.
It feels much more honest. So, digging into the history and our sources, the concept of measuring this gap between cure and poison actually has a fascinating backstory. It goes back to the early 1900s to a German physician-scientist named Paul Ehrlich.
Right, Ehrlich.
He was hunting for a treatment for syphilis, and at the time, treatments often involved heavy metals like mercury and arsenic.
The biological challenge Ehrlich faced was just monumental. Heavy metals are indiscriminate killers. I mean, they disrupt basic cellular functions in almost all living things.
So they were basically poisoning the patient to kill the disease.
Exactly. The medical goal was to find a chemical structure that preferred to bind to the syphilis pathogen rather than the patient's own cells. Ehrlich called this the search for a magic bullet.
He tested hundreds of arsenic-based compounds until he found compound 606, which was later marketed as Salvarsan. But reading his notes, he didn't just want a drug that sort of worked. He wanted a way to quantify its safety margin.
Yeah.
And he coined the term chemotherapeutic index. But here's what I found really interesting. Ehrlich gave us the concept, but he didn't actually come up with the math we just talked about. That took another 20 years.
Right. The statistical machinery to actually measure Ehrlich's concept came in 1927 from a British pharmacologist and statistician named J.W. Trevin.
And Trevin wasn't even looking at syphilis. He was trying to solve a terrifying problem with biological products like insulin and diphtheria antitoxin. Back then, they were extracted from animals.
Yeah, which meant their potency varied wildly from batch to batch. Regulators desperately needed a standardized way to compare these batches.
Because if a batch of insulin is too strong,
It's fatal. Trevin realized that trying to find a single absolute lethal dose for any drug was scientifically impossible because individual animal biology varies too much. One mouse might be highly resistant, another highly sensitive.
so what did he do?
Well, he found that if you calculate the dose that kills exactly half of a large, standardized population, that median number is statistically stable. It forms a reproducible bell curve.
That is brilliant. He gave us the LD50 concept purely as a statistical anchor to make sure batches of insulin were consistent before they went to human patients.
Exactly.
Okay, so that is the history and the math. But let's bring this into the real world. Let's talk about the unforgiving drugs, the specific narrow therapeutic index drugs, where this math becomes a literal matter of life and death. The first example from our sources really shocked me. Digoxin?
Digoxin is derived from the foxglove plant, and it has been the classic textbook example of a narrow TI drug for decades. It's used heavily for heart failure.
How does it work?
Biologically, digoxin works by inhibiting a very specific mechanism in heart muscle cells called the sodium-potassium pump. By partially blocking this pump, the drug causes calcium to build up inside the heart cells, which forces the heart muscle to contract with much more force.
Which is exactly what you want if someone's heart is failing and not pumping hard enough.
Right.
Historically, the accepted therapeutic window for digoxin in the blood was cited as 0.8 to 2.0 nanograms per milliliter. That was a safe parking spot.
But if you block too many of those sodium-potassium pumps, the heart muscle cells become electrically unstable. They can't reset their charge properly, leading to fatal arrhythmias. The heart just stops beating in a coordinated rhythm.
That's terrifying.
And for decades, the medical field believed that as long as a patient was under that 2.0 limit, they were safe from this toxicity.
Then came the 1997 DIG trial and a massive reanalysis of that data by Rathor and colleagues in 2003. They found something horrifying. Patients, and particularly women, who had serum digoxin concentrations above roughly 1.2 were actually experiencing worse survival rates.
not just mild side effects.
Right, they were dying at higher rates than patients with lower levels.
The accepted safety margin was fundamentally mathematically wrong for decades. The toxic threshold had been vastly underestimated. It resulted in a massive guideline-level correction across the entire medical field. Modern practice now targets a much lower, tighter window of roughly 0.5 to zero point 0.9 nanograms per milliliter.
That is deeply unsettling because it shows that these textbook numbers aren't handed down on stone tablets. They are hypotheses that can be proven wrong by real-world data.
Absolutely.
Now, with digoxin, the danger was that our accepted safety window was just wrong. But with some drugs, the window is perfectly accurate, but the human body's metabolism is completely unpredictable. That's the case with our next drug, warfarin. Here's where it gets really interesting. This origin story is unbelievable.
It really is. The origin of warfarin is one of the most counterintuitive stories in medical history. It begins in the 1920s across the American and Canadian prairies. Cattle were suddenly dying in the fields from massive, unexplained internal bleeding.
A biochemist named Carl Paul Link at the University of Wisconsin started investigating. And he traced the cause back to the cows eating moldy sweet clover hay.
Yeah, the mold was the key.
By 1940, his lab isolated the natural anticoagulant compound in the mold that was causing the bleeding, which was called decumarol. They synthesized a more potent version of it, but they didn't turn it into a medicine for humans. In 1948, it was patented as a rat poison.
Yeah, it was heavily marketed and sold strictly as a rodenticide. They named it warfarin, the WARF standing for the Wisconsin Alumni Research Foundation, which funded the research. The idea of giving a highly effective rat poison to humans seemed completely absurd to the medical establishment.
Until President Dwight D. Eisenhower had a massive heart attack in 1955, his doctors decided the risk of a blood clot was so high that they treated him with warfarin. Suddenly, the rat poison was a life-saving presidential medicine.
And today, it is one of the most widely prescribed blood thinners on Earth.
That is wild.
But its roots as a toxin demand profound respect in a clinical setting. Warfarin works by blocking the liver from recycling vitamin K, which is essential for creating blood clots. The biological problem is that a patient's response to warfarin varies enormously based on genetics.
How so?
Warfarin is processed in the liver by specific enzymes. Think of them as the liver's chemical scissors, specifically one called CYP2C9, and it targets a protein called VKORC1.
And because every human being has slight genetic variations in those chemical scissors, there's no such thing as a standard dose. You cannot just give two random people 10 milligrams and expect the same amount of blood thinning.
Exactly.
Plus, because it blocks vitamin K, eating a large salad full of vitamin K-rich spinach can completely override the drug.
This is why patients on warfarin must undergo relentless routine blood monitoring. Clinicians use the INR, the International Normalized Ratio blood test, usually targeting a strict window of 2.0 to 3.0.
And if they don't?
If you don't monitor it, the genetic and dietary variables take over. The patient either forms a lethal clot or bleeds uncontrollably. There is no middle ground.
So genetics make warfarin incredibly difficult to manage. But moving to our third example, sometimes the danger isn't your genetics, it's your daily environment. Let's look at lithium. It is a foundational treatment for bipolar disorder. The therapeutic range is incredibly narrow, roughly 0.6 to 1.2.
Lithium truly sits on a razor's edge. Once blood levels drift just a tiny bit above 1.5, patients start experiencing ataxia, which is a complete loss of muscle control and coordination.
Wow.
Yeah, along with severe tremors and confusion. Push above 2.0 and you are looking at life-threatening seizures, arrhythmias, and potentially a coma.
I was reading about how lithium is processed, and it raises a fascinating point about how easily our bodies can betray us. Lithium's clearance from the blood is completely controlled by the kidneys, but the kidneys can't easily tell the difference between a molecule of lithium and a molecule of common sodium.
To the kidney's filtration system, they look chemically identical. This means lithium clearance is tightly bound to how your body handles salt and water.
So if you get dehydrated on a hot summer day, or you get the flu and run a fever, or even if you just take an over-the-counter NSAID like ibuprofen.
Yeah,
so,
cheap weight.
Does that mean
Your kidneys panic about the sudden lack of fluid or sodium. They start aggressively reabsorbing sodium back into the blood to save you. But because they can't tell the difference, they reabsorb all the lithium right along with it.
a perfectly stable patient who has taken the exact same dose of lithium every single day for years can suddenly be thrown into a life-threatening toxic state simply because they got sweaty working in the garden and didn't drink enough water?
It's wild. The dose never changed, but their body's ability to clear it plummeted. That is why lithium patients require heavy counseling on consistent hydration and diet.
So biology, genetics, and environment make these drugs incredibly difficult to manage. But reading through the modern case studies in our sources, it becomes clear that sometimes it isn't the biology that fails, it is the human systems around the drugs. Narrow-margin drugs don't only fail in the bloodstream, they fail in the supply closet.
The Cedars-Sinai incident from 2007 is a tragic textbook example of this system failure.
This was a massive national news story. The actor Dennis Quaid had newborn twins in the neonatal intensive care unit, and they were accidentally given a massive overdose of heparin, a blood thinner. They received roughly 1,000 times the intended infant dose.
It's hard to even comprehend.
1,000 times. How does a modern hospital make an error that massive?
To understand why this error was so catastrophic, you have to look at how heparin works.
Good.
Unlike warfarin, which takes days to alter the liver's production of clotting factors, heparin binds to a protein in the blood called antithrombin and instantly supercharges it.
Meaning?
It shuts down the body's coagulation cascade in seconds. It stops blood from clotting immediately.
So a massive overdose means the blood instantly loses all ability to stop bleeding. And the reason they got that overdose wasn't a complex biological mystery. It was literally a packaging failure. The adult-strength vials of heparin, which contain 10,000 units per milliliter, looked nearly identical to the infant-strength Heplock vials, which contained only 10 units.
Just unbelievable.
The labels had similar blue backgrounds. They were the same size, and they were stocked in the exact same area.
Storing those vials together is like storing a bottle of industrial acid right next to identical bottles of eye drops. The twins thankfully survived after emergency intervention, but the incident fundamentally changed hospital protocols nationwide.
Right. It forced organizations like the Institute for Safe Medication Practices to place heparin, along with insulin and opioids, on a strict list of high-alert medications. These drugs now require mandatory double checks by 2 different nurses and physically separate storage.
Yeah, it's not that errors happen more often with these specific drugs, but because the biological mechanism is so rapid and the margin for error is so thin, a simple mix-up is instantly catastrophic.
This razor-thin margin also drives a massive ongoing scientific and regulatory debate about generic drugs. I saw this in the FDA guidelines. The FDA, the European Medicines Agency, and individual state pharmacy boards all have slightly different criteria for what officially counts as a narrow-therapeutic-index drug. But why does that bureaucratic definition matter to a patient at the pharmacy counter?
It matters deeply when it comes to generic substitution. When a generic drug is approved, it doesn't have to be identical to the brand name down to the molecule, it just has to be bioequivalent.
Meaning it performs the same way in the body.
Right. Regulators use complex statistics to measure how much of the drug gets absorbed into the blood over time, known as the area under the curve.
And the standard FDA rule allows for a statistical variance, right? The generic's absorption can fall anywhere between 80% and 125% of the brand name drug and still be legally considered equivalent.
Exactly. And for a wide TI drug, like a common antibiotic, if your blood absorbs 15% less of the generic version, you would never notice. The drug still works perfectly. But mathematically, if you switch a patient from a brand name NTI drug to a generic, and their absorption shifts by 15%, that tiny statistical swing might push them completely out of their safe clinical window.
Oh, wow. So a 15% drop means their warfarin stops working and they get a blood clot. A 15% spike means they bleed out.
Yeah.
That explains why many U.S. states legally restrict pharmacists from automatically substituting generic versions of certain NTI drugs without the doctor's explicit permission. The statistical math that works for most drugs is just too loose for the unforgiving ones.
That's a great way to put it.
Because these drugs sound so difficult and, frankly, terrifying to manage, it is easy to misunderstand them. The sources highlighted a few dangerous myths that we need to clear up. Myth number 1. If a drug has a narrow therapeutic index, it is inherently a bad drug. If they require so much work, why not just avoid them?
Well, narrow-TI is a strict monitoring instruction, not a warning to avoid the drug entirely. We use them because their therapeutic benefits are irreplaceable. Lithium stabilizes life-threatening bipolar episodes in a way nothing else can. They simply demand a clinical protocol called therapeutic drug monitoring, or TDM.
TDM is the reason hospitalized patients get woken up at 4 a.m. for a blood draw. Nurses have to measure the peak level, the highest concentration of the drug right after a dose, and the trough level, the lowest concentration right before the next dose, to ensure the patient's biology hasn't pushed them out of the window.
Right. Clinicians will often use a large loading dose to force the drug levels into that narrow window quickly, and then use tiny, precise maintenance doses to keep them balanced there. The chemical isn't bad, it just demands extreme clinical discipline.
Okay, myth number 2. Scary-sounding, heavily regulated drugs are always the ones with the most dangerous, narrow margins.
This reveals a fascinating psychological bias in how we view risk. Some highly feared, heavily controlled substances actually have quite wide therapeutic indices. Benzodiazepines, for example, when taken strictly in isolation, have a lethal dose that is incredibly high compared to their effective dose.
So the twist is that a drug doesn't have to be a controlled prescription substance to be narrow and dangerous.
Exactly. Look at acetaminophen, also known as paracetamol. It is sold over the counter, sitting in practically everyone's medicine cabinet, completely unregulated for adults. Yet it has a deceptively narrow gap between a normal therapeutic dose for a headache and a hepatotoxic dose that permanently destroys your liver cells.
Wait, really? Tylenol has a narrow margin. How does that work biologically?
When your liver processes acetaminophen, it creates a highly toxic byproduct. Normally, your liver uses a natural antioxidant called glutathione to instantly neutralize that toxin.
Okay, so the body handles it.
Right, but your liver only has a limited supply of glutathione. If you take just a little too much acetaminophen, you completely deplete that antioxidant defense. The toxic byproduct builds up and causes rapid liver cell death, known as necrosis.
Which makes acetaminophen overdose a leading cause of acute liver failure. People assume that because it is familiar, cheap, and easy to buy at a gas station, the margin of safety must be massive. It is not. Familiarity is a terrible guide to safety.
It is the absolute worst guide to safety.
So if we connect this to the bigger picture, why does this matter beyond passing a pharmacology exam? It matters because the therapeutic index is the invisible architecture behind almost all frontline healthcare. When a nurse does a mandatory double check on an IV bag, when they schedule that 4 a.m. trough lab draw, when they sit down and teach a patient to watch for visual halos with digoxin or unusual bruising with warfarin, they are actively managing that razor-thin margin. They are keeping the patient from falling off the cliff.
And you can see the catastrophic results when that architecture is missing. The current opioid crisis, particularly with fentanyl, is fundamentally a therapeutic index problem.
Right, because fentanyl's extreme potency compresses the gap. The distance between the dose that relieves pain and the dose that shuts down the brain's drive to breathe is extraordinarily thin.
Without a controlled clinical environment to enforce that microscopic window of safety, an unregulated, illicitly manufactured pill on the street becomes instantly lethal. The margin for error is simply gone.
It is a terrifying, real-world echo of everything we've discussed today. This has been incredibly eye-opening. Thank you for diving into the mechanisms with me.
Happy to do it.
So, what does this all mean for you, listening right now? The most crucial takeaway from our deep dive into these sources is that a drug's safety margin isn't a fixed magical number permanently printed on the plastic bottle. It is a living, breathing window that shrinks and shifts based on your genetics, your age, how well your kidneys are filtering, how much water you drank today, or even what you eat for dinner. Next time you take a medication, even a simple, familiar, over-the-counter painkiller from your bathroom cabinet, ask yourself, how much error is this drug actually forgiving today?